Hi guys, good evening. Can you all see me? Can you all hear me? Can we start? So, Ram Ram Rahul. Good morning, guys. Sorry, good evening, good evening, good evening. Hi, Mansoor, good evening. Hi, Rakta Mukherjee. Hi, guys, good evening. So, as it was decided, we wanted to do an additional extra series on BLS. Normally, we said BLS was going to be 3 days a week. I got a lot of messages on Instagram as well, on the Telegram group as well, saying that, sir, let's continue a bit more. So I thought, oh, why not? Let's accommodate today's Children's Day. Happy Children's Day to all of you. So extending the series on the Children's Day is going to be quite amazing. Thank you so much for all the love and support which we're getting for BLS series, and we will make sure that we run it all through across. Take care. Hi Priyanshu. Good evening, guys. Good evening. Good evening, Vinay. Right. So without wasting any further time, let's kickstart the discussion on today. So we'll be continuing on the thyroid swelling series and try to, get across a grip of, how goiters are being presented, how we are going to treat goiters and all. Before we move down, there's something that I would like to address. It has been there for a while. I mean, you might be following news and all. So see, it's more like an epidemic that has been there in India right now. It's about the violence in our particular field, like the violence on doctors. Uh, See, no human being is allowed to be manhandled or to be very honest, the way particularly a person has been dealt recently is quite sad. As a doctor, as a practicing surgeon, I can tell you every single day we meet a lot of people. We meet people from different backgrounds. We meet people from different mindset. People come with different problems, right? And as a person, when I'm looking at different people with different problems, it is actually overburdening. It's overwhelming that you listen to all these guys and then trying to provide them the treatment to best of your ability. Yes, as a doctor, we do lose cool sometimes because the work is such and the burden is such, but that does not give anybody any right to be violent, right? So it's the same saying, no? For example, you go to a temple, you ask a wish from the god, hoping that God would grant you a wish. If the wish is not granted, you don't go back to the temple and destroy it, right? If you are going to a place of faith, you are coming to the hospital with the same faith that you have in doctors. So it's an urge to our greater public that consider us as one of the most hardworking souls on the earth. We do take care of our patients. We do love our patients. We do whatever is best to our abilities. But if something happens of this sort, it's not acceptable, right? So with that, all the friends and doctors and colleagues who are out there, one single message: stay united. Keep you need to have that subset of friends and colleagues around you. Whenever a patient is turning violent or being abusive, the best thing to do at that time is to avoid a conversation. Don't confront that patient. Just walk away from there. Make sure the management is getting involved. Make sure the security guys are around, and then do your duty. Safety is always important, and I urge every single doctor, especially the young guns, do curb that impulse of responding. Because if a person is stupid, you don't need to answer that particular person, right? So in that context, I would wish everybody to stay safe. We're doing a great job. We'll continue to do no matter what. Even though the recent incidents of the Chennai where the doctor has been stabbed, the irony of the thing is, even in that hospital, uh, every other uh, services have been stopped, but not emergencies, right? So no matter how difficult it gets for us, we don't stop working. We do care for people who actually require us. Okay. On that note, let's start a discussion today. I wanted to address this. This has been there for a while in the different contexts. I wanted to address this as well. So if you have any such incidences, make sure stay safe, and if you want to address, do address, and do want to share, do share with us, right? So with that, let's kickstart our series, that is BLS, for today. Yesterday we left at your ectopic thyroid gland. In the same congenital swellings, I would like to give you another example of the thyroglossal duct cyst. So we were talking about the thyroglossal Thyroglossal Duct Cyst. So we're talking about the Thyroglossal Duct Cyst. Now, by definition, as the name itself is telling you, that a thyroglossal duct is converting into a cystic swelling, right? As simple as that. It's a thyroglossal duct converting into a cystic swelling. So what is a thyroglossal cyst? A thyroglossal cyst is basically, it is a cystic swelling. It is a cystic swelling in the midline of the neck. In the midline of the neck. It's a cystic swelling in the midline of the neck, and this is due to the remnant. This is due to the remnant of thyroglossal duct, right? So say it's a cystic swelling in the midline of the neck, and this cystic swelling in the midline of the neck is because of the remnant of the thyroglossal duct. Now, when you talk about the thyroglossal duct, we already spoke that it is going to arise in the median diverticula in your embryonic development. Then it goes down, it combines with the lateral algae together. When it fuses, it develops into a thyroid gland. Now, you need to understand that the thyroglossal duct starts to obliterate. It starts to obliterate as early as the 5th week of gestation, and it completely obliterates. That is, thyroglossal duct completely obliterates. It completely obliterates by the 8th week of gestation, right? So the obliteration starts by the 5th week, but it ends by the end of the 8th week. So when you say there is a remnant of the thyroglossal duct, what do you actually mean by this, right? Now imagine that you have a patient which has been represented across here in this particular fashion. Let's say this is all represent the patient, and this happens to be the neck, and this goes across here. You have the tongue, which we already discussed. Let's say this is where the position of the tongue is being placed. So this is how the tongue is represented. Then you have the hyoid bone. Let's say this happens to be the hyoid bone. This happens to be the hyoid bone that we have. Then this is the thyroid cartilage. This happens to be the cricoid cartilage, and this continues to be your trachea. So this continues to be the trachea that is going down across here, right? We've already dealt with this. So look here. This is the hyothyroid membrane that you have. This is the thyrocricoid membrane that is going to be present across here. We've already dealt that the foramen cecum, which is going to be present, is going to be between a junction of the anterior 2/3 and the posterior 1/3 of the tongue, and this is the location from where the thyroglossal duct is going to arise. Now the journey of the thyroglossal duct usually goes behind the hyoid bone. It pierces the hyoid bone. It is going to go and deliver the gland at its desired site. And once the gland is delivered as a desired site, you will now notice that the duct which is present here, the thyroglossal duct, will start to disintegrate, and the disintegration will be in a retrograde manner. That is going to be in a caudal. This is going to be towards the cranium. So caudocranial. It is from the foot to the head. That is caudocranial disintegration of the thyroglossal duct is going to take place. Now it so happens that when it comes to the level of the hyoid bone, if I isolate the hyoid bone, let's say this is how I would represent the hyoid bone which is present here. Now when it comes to the level of the hyoid bone, you see something very peculiar is happening. Now what is happening is, you will notice the thyroglossal duct which is traveling all the way across here. When it reaches to the lower surface of the hyoid bone, it is going to turn and then going to come out in this particular fashion. It is going to turn and then it is going to come out in this particular fashion. So it goes under the hyoid bone, and you can see the area from where it is taking this turn. The area from where it is taking the turn, it is exerting. So it's like this, right? You see, this is the hyoid bone that is present, and you see the duct which is coming here, it is looping across here. I would like you to get this idea. Just give me a second. All right, so get this, right? We say this is the thyroglossal duct and a different background, so that, okay, to create the background, we're going to add a page. I'm going to, yep, I'm going to add a black one, apply, and I get a page. Now I got a background. Okay. Now you need to understand it this way. Imagine this is the thyroglossal duct. Okay. Now this duct is going to go. It is coming from the tongue, that is from the foramen cecum. It is descending. Now as it comes to the level of the hyoid bone, it is becoming like this, right? It pierces the hyoid bone and it is becoming anterior. It is piercing the hyoid bone. As it pierces the hyoid bone, it is becoming anterior. You can see this point where it is piercing, at this particular point, it gets compressed, right? As it is arching out, you see the duct is getting compressed at this point. Now, as the duct is getting compressed at this point, the compression at this point is going to cause an issue. What is that issue? You will now notice that the duct which is present, if I isolate the duct at the level at which it is curbing, this is how it is present, right? Now why this is important is, once the duct starts to obliterate, you will see the obliteration is going to be the caudocranial direction, but for obliteration to continue, the duct has to remain patent. But when it reaches to this point where the duct is collapsed, the body perceives or thinks the duct is already collapsed. It is already compressed. Now what is going to happen? It is going to stop. So the obliteration stops at this particular level because it appears as if the duct is already obliterated. We have discussed yesterday, day before yesterday, on the first day of our lecture, that the thyroglossal duct which is present is going to have the epithelial lining. It is lined by an epithelial surface. The thyroglossal duct, it is lined by the epithelial surface. Remember, the epithelial surface of the thyroglossal duct in future develops into thyroid follicles. Now what is going to happen? Now because the duct is obliterated and it is stopping, you will notice that all the secretions which are present, because they are glandular, they'll have secretions, so all the secretions will start pooling into the thyroglossal duct. As more and more secretions will continue to pool, as more and more secretions are going to pool, what is going to happen? The bottom end or the dependent end of the duct is now going to become heavier. Now as it becomes heavy, it is going to have this cystic dilatation. You'll notice that as more and more amount of fluid, it is going to get accumulated. As more and more amount of fluid is going to get accumulated, you will notice that this area is only going to get heavier, right? So initially, even though the patient is presented with this kind of presentation, initially, if this is the presentation, these are the cells which are present, they're secreting. Now as they continue to secrete, what is going to happen? They are going to get deposited in the dependent area. Now as it gets deposited in the dependent area, this is only going to get bigger and bigger. Now as it gets bigger and bigger, because of the collection, the upper end will become narrower and it will continue to make narrow, right? If you remember, I also told the origin of the thyroglossal duct is from the foramen cecum, which is going to be the junction between the anterior 2/3 and the posterior 1/3 of the tongue. So this whole component which is present here, this is actually attached to the tongue which is present here, right? So you can notice that eventually if you isolate this, so you have the kink effect, which is not allowing it to obliterate completely. Because it is not able to obliterate completely, the secretion will start pooling. Now as the secretion will start pooling, it will now going to become a cystic swelling and it will continue to become heavy. Now as it continues to become heavy, if I isolate this particular diagram, you will notice that this is the base of the tongue that we're talking about. This is the base of the tongue that we are talking about. And on this surface, you have the hyoid bone that is present across here. So this is the representation of the hyoid bone that we have. And we are now saying that the thyroglossal duct, which fails to regress, is now going to originate from this point, which is going to be here. Now because it is not able to obliterate completely, you will see now this is going to become into a huge cystic swelling. Now this huge cystic swelling is because of all the collection that is present. Now as you can see, as more and more amount of fluid is going to get accumulated, as more and more amount of fluid is going to get accumulated, you will notice the cyst is only going to become bigger and bigger in size, and the upper end of the thyroglossal duct will collapse to form a band, and that band will be attached. That band will be attached to the base of the tongue, right? Now, if you look at this representation, you will now notice that this is the patient who is going to present to us. This is the patient. Let's say this is the neck which is present. In the midline of the neck, it will present to you as a swelling. It will present to us a midline neck swelling that is going to be present. Now, when you look at the sites, no, when with respect to the hyoid bone, where are the sites you can find this cystic swelling to be attached? So when you look at this sites, the sites where it is going to be attached, it is usually either attached on the superior surface or it will be attached on the inferior surface. So either you will have a cyst that is going to be attached on the superior surface, that is what we call it as the suprahyoid in location. This is what we call it as the suprahyoid in location. On the other hand, it can be attached onto the inferior surface, that is what we call it as the subhyoid, or also called as the the behind the hyoid bone or the retrohyoid position. Okay? So you can have the position in which you can assume these swellings to be existent above the level of hyoid bone. This is what we call it as the suprahyoid. This is what we call it as suprahyoid. This is what we call it as, either you can call it as sub or also referred to as the infrahyoid in position. Now, out of these two locations, 65% of the patients of the thyroglossal duct cyst, 65% of the patients of the thyroglossal duct cyst usually present to you with sub or infrahyoid in location. With sub or infrahyoid in location, right? And obviously this is now attached to the band, and that band is attached to the base of the tongue, right? So this is how the thyroglossal duct cyst is going to be formed. In a quick recap, if I tell you, it all starts with the improper disintegration, or I can say incomplete disintegration of the thyroglossal duct, right? So we say it's a cystic swelling in the midline of the neck that fails to regress with time during the embryonic development. Hence, that persistent thyroglossal duct converts into a cyst, which is now attached with a band to the base of the tongue. As simple as that. So how will this patient present to us? So what is the clinical presentation of this particular patient? So even though it's a congenital disorder, the usual age of presentation is seen around the second decade of life, and it is more common in females when compared to males. Now, see, when you talk about thyroid disorders, now we'll always tell you that majority of the thyroid disorders are more common with females when compared to males. One of the reasons is the thyroid follicular cell consists of an estrogen receptor on their surface. So whenever the estrogen fluctuation is going to happen, it is going to cause a fluctuous stimulus on the thyroid follicle. Hence, that differential stimulus in the thyroid follicles can lead to majority of the potentiated damages or the disorders or diseases in the thyroid gland. Whereas, because the estrogen level keeps fluctuating in a female in its life cycle, during puberty it is different, during menstrual cycle it is different, in pregnancy, post-pregnancy, so it continues to fluctuate. So hence follicular stimulus will also continue to fluctuate. So hence it is more common in females when compared to males. Now, how would these patients will present to you? The classical presentation of these patients would be presence of a midline neck swelling. It will present to you with midline neck swelling, right? So when you talk about midline neck swelling, what are the midline neck swellings that I can think about? Now, in the midline of the neck, the swellings that I can probably think about in terms of the differential diagnosis. So midline neck swelling, what are the differential diagnoses that we have? Number one, it could be a thyroid swelling, which is going to be the most common guess that we would take. If it is not there, the second one is going to be the thyroglossal. It is a thyroglossal duct cyst. The third one is going to be subhyoid bursitis. It could be a subhyoid bursitis. It could be a subhyoid bursitis and enlarged pretracheal lymph nodes. And enlarged pretracheal. It is an enlarged pretracheal lymph nodes, right? So these are the four swellings These are the 4 swellings that can present to you as a midline neck swelling, right? This is going to be a midline neck swelling. Now, problem is, how do you know that is a thyroglossal duct cyst, right? So you are going to evaluate. The only complaint will be presence of midline neck swelling. So when you examine this patient, on examination, obviously, okay, if you add a point, this is going to be another one important would be it is painless and it will be gradually increasing in size. It would be gradually increasing in size, right? So we've already dealt that the progression of a swelling can be gradual, it can be rapid, it can be sudden. Gradual, it is going to be whenever a swelling is present, when it doubles. The doubling time is going to be from months to years together. We call it as a gradually increasing in size, and that usually associated with benign swellings. When I say rapidly increasing in size, the doubling times is going to be weeks to months. It is usually associated with malignant disorders, and suddenly increasing in size can take from hours to days, usually associated with inflammatory and traumatic swellings. Okay? Hi Vanshika, welcome. So, in this context, you need to take care that these are the DDs that we are going to talk about it. Now, you have a patient who is going to have a midline neck swelling which remains painless and it is going to gradually increase in size. Now, I want to evaluate this, right? So, on examination, what are the findings? What are the findings that we're going to talk about? Now, we'll be talking in detail about the clinical examination series also. I'll be talking about whenever you examine a patient, there are 2 parts of examination. There is inspection, there is palpation. Inspection is you see, palpate, whatever you've seen, you want to touch, feel and confirm. Okay? So on examination, what are we going to find? Number 1, you will see that it is going to be a non-tender swelling. Patient would let you touch it. It is non-tender swelling. When you touch it, it is going to be uniform. That means it will have a smooth surface. This is going to be having a smooth surface. So it's a non-tender swelling. It is going to be uniform. It is going to have a very smooth surface when you are going to palpate this. More importantly, you will notice that this is going to move upwards with deglutination. That means every time the patient is going to swallow, you will see that this swelling is going to move upwards. It is going to move upwards with deglutination. Now, what are the other swellings that can move upwards with deglutination? So, midline neck swelling that moves upwards with deglutination are the same swellings that we have just discussed. That it could be our thyroid swelling. It could be our thyroid swelling. It could be your thyroglossal duct cyst. It could be your subhyoid bursitis. It could be our subhyoid bursitis or an enlarged pretracheal lymph nodes or the enlarged pretracheal lymph nodes or an enlarged pretracheal lymph nodes. An enlarged pretracheal lymph nodes, right? So these are the various swellings that can move upwards with deglutination. Now my question to you is, why would all these swellings move upwards with deglutination? Or I'll make it more precise. Why does the thyroid swelling move upwards with deglutination? A quick feedback. All those who are watching live, guys, I want you to get involved. I want you to dig in with the questions. I want you to challenge every single thing I tell. If you're not understanding, ask me again. If you don't understand the concept, I'll repeat again. But I don't want you to go down from here without understanding any single point that we are uttering. So my question to you is, if I say there is movement with deglutination in a thyroid or a thyroid associated swelling, why does it move upwards? Alright guys, ठीक है, असगर गॉट इट. तो असगर सवाल ये है कि मैं बोल रहा हूं कि थायराइड स्वेलिंग है, थायराइड एसोसिएटेड स्वेलिंग जो भी होता है वो डीग्लूटिनेशन के साथ मूव करता है. ठीक है, मतलब जब भी आप कुछ स्वॉलो करते हो वो मूव करता है. मेरा सवाल ये कि मूव क्यों करता है? Why does it move? Rahul, bang on beta, absolutely correct. So Rahul has given us an answer. It says Berry's ligament. Congratulations Rahul, you are absolutely correct. लेकिन बेटा ये Berry's ligament होता क्या है? What is this Berry's ligament? Now to understand the concept of movement with deglutination, So we'll talk about why does the swelling move upwards with deglutination. So we'll understand the concept of movement with deglutination. It is going to be movement with deglutination. So why does it move upwards with deglutination? So the whole concept lies in this small component or a here that we call as, it is because of the investing layer of deep cervical fascia. It is the investing layer of the deep cervical fascia which is going to condense, which gets condensed, and now this condensed investing layer of the deep cervical fascia is what we call it as the Berry's ligament. This is what we call it as the Berry's ligament, right? So any normal guy would tell you कि ठीक है, याद रख लो कि movement with deglutination Berry's ligament की वजह से होता है, और Berry's ligament जो है, it is nothing but your condensation of investing layer of deep cervical fascia. But beta, we are not somebody, we are not anybody, we are special. तो हम special तरीके से सीखेंगे कि Berry's ligament होता क्या है, ठीक है? अब when you talk about this Berry's ligament, it's quite interesting. Now if you look at the arrangement, you look at this as a representation of the patient that we have. Let's say this is the head of the patient, this happens to be the ear, and let's say this is the mandible. Let's say this is the neck of the patient that we're talking about, and then this happens to be the sternum. We're not much worried about it. You see, this happens to be the hyoid bone. We have been talking about it since the beginning. This is going to be the thyroid cartilage that is present here. This happens to be the cricoid cartilage that is present here. And then you have your trachea, which is continued. Okay? So you have the hyoid bone, you have the thyroid bone. So this is hyoid, this is thyroid and cricoid. I'm not going to label it. We have done quite a number of times. So this is your hyothyroid membrane. This happens to be the thyrocricoid membrane. Okay? Now, what is this investing layer of deep cervical fascia? Just to get an understanding, let's say this is where our thyroid gland is going to be present. Okay? Now, this investing layer of the deep cervical fascia, when you look at the arrangement, this happens to be the orbit and this happens to be the zygomatic arch. Right? This investing layer of the deep cervical fascia starts all the way from the occiput. It starts all the way from the occiput, comes behind the ear. It becomes anterior, attaches to the inferior surface of the zygomatic arch, continues its journey and goes and encircles the thyroid gland. It goes and encircles the thyroid gland, right? So if you look at this investing layer of the deep cervical fascia, which starts behind the occiput, encircles the ear, it covers two other glands. If you notice, there's one gland that is going to be present here. This is going to be a parotid gland. There's another gland which is going to be present here. That is going to be a submandibular gland. So the parotid and the submandibular gland are going to be covered in this particular fashion. So the investing layer of deep cervical fascia does not only cover the thyroid gland, it covers the other two glands also, which is going to be the parotid and the submandibular gland. Wherever this is going to cover, this covering is what we call it as the pseudocapsule. So pseudocapsule of the parotid gland, the pseudocapsule of the submandibular gland, and the pseudocapsule of the thyroid gland. All this is formed by the investing layer of the deep cervical fascia. So for the sake of understanding, I'm just going to label it. This is going to be our investing. This is the investing layer of deep cervical fascia. It is the investing layer of the deep cervical fascia. So where is this Berry's ligament? Now you will notice that investing layer of deep cervical fascia, if you look across it, this is the pretracheal fascia, which I'm showing you in green, right? So this is your pretracheal fascia that is present. So this is your pretracheal fascia. This is going to be your pretracheal fascia. So the investing layer of the deep cervical fascia, which is condensing together, and then there is this initial attachment of the trachea, which is called as pretracheal fascia. Now this investing layer of deep cervical fascia that is coming from the occiput and comes and covers anteriorly like this. Now when it is coming and covering anteriorly, the posterior surface of this is going to condense. Now when the posterior surface condenses, the condensation will result in a band, and that band is going to be attached to the pretracheal fascia. So this band that is attached, this attachment or this band that is attached is what we call it as the Berry's ligament. This is what we call it as the Berry's ligament. This is what we call it as the Berry's ligament. This is what we call it as the Berry's ligament, right? So the pretracheal fascia, it is going to get attached, or the investing layer deep cervical fascia, which is going to encase the thyroid gland, condenses on the posterior inferior surface and then attaches to the pretracheal fascia, and this attachment is what we call it as the Berry's ligament. Now, it is very interesting that the cricopharynx, which is going to be in continuation with the thyroid and the cricoid cartilage apparatus. So you need to understand that if this is your trachea and this is the Berry's ligament, this is the thyroid gland that is present. So this attachment that you can see right across here, right? So this is the trachea that you have, this is the trachea that you have, this is the thyroid gland that is present here, and this is your Berry's ligament. So every time the patient is going to swallow, because of the cricopharyngeal movement, the trachea is going to be dragged up. Now as the trachea moves up, because it is attached with the Berry's ligament is also going to pull the thyroid gland. मोटा मोटा ये बोलना चाह रहा हूं कि जितना भी आपका इन्वेस्टिंग लेयर डीप सर्वाइकल फेशिया है, जो ऑक्सीपुट से शुरू हो रहा है, कान के पीछे से आके जाइगोमैटिक आर्च के नीचे लग के फिर सीधा नीचे जाके थायराइड ग्लैंड को एनकेस कर रहा है, थायराइड ग्लैंड के पोस्टीरियर इंफीरियर सरफेस पे एक बैंड बन जाता है और वो बैंड जाके चिपक जाता है आपके प्रीट्रेकियल फेशिया पे. सो जब भी प्रीट्रेकियल फेशिया इसके साथ कनेक्टेड है ना, तो अब क्या होगा, एवरी टाइम द पेशेंट इज गोइंग टू swallow, the cricopharynx is going to move upwards. Now as it moves upwards, the hyoid is going to be pulled up. So because the hyoid is pulled up, obviously the pretracheal fascia is pulled up. As the pretracheal fascia is pulled up, the Berry's ligament is now going to be dragging up. Now when there is a pressure or there is a force on Berry's ligament to move up, obviously because the gland is attached to this, now it is pulled up, the gland is also going to move upwards. The movement with deglutination is because of this small tiny attachment that you have. It is going to be your Berry's ligament. ठीक है? Is that clear? Is that clear? आई बात समझ में? Did you all understand what is this Berry's ligament? Right? Now the clinical relevance is, if a swelling is moving upwards with deglutination, I know that it is associated with thyroid or pretracheal fascia. Either it is attached or it is associated with thyroid associated swelling, or it is attached to the trachea, because these are the components which can move upwards with deglutination. So you know that the three glands which are going to be present, or it is going to be encased by this pretracheal fascia. Those three glands are going to be your parotid gland, your submandibular gland, and this is a thyroid gland. This is a thyroid gland. Now, interesting thing about the thyroid gland, when you look at this, if you take this as the representation of the thyroid gland, if I just take the cross section of the thyroid gland, you will see that the thyroid gland is covered by its own capsule. It is covered by its own capsule, which is adherent to the thyroid gland. It is inseparable, and this is what we call it as the true capsule of the thyroid gland. This is what we call it as the true capsule of the thyroid gland. And then you see this attachment that is present. This is the condensation of the investing layer of the deep cervical fascia, and this is what we call it as the pseudo capsule. This is what we call it as the pseudo capsule of the thyroid gland. Now, true capsule, it is inseparable. It is inseparable from thyroid gland. It is inseparable from the thyroid gland. Whereas pseudo capsule, it is derived from the investing layer of the deep cervical fascia. So it's a condensation of investing layer of deep cervical fascia. It is the condensation of the investing layer of the deep cervical fascia. So you now know what is a true capsule is. You know what is a pseudo capsule. You know the true capsule is because of the gland that is getting adherent, and the pseudo capsule is just the deep cervical fascia that is condensed. Is that clear? आई बात समझ में? Perfecto, perfecto. ठीक है? Now, when you talk about this Berry's ligament, no. So you now know what's a Berry's ligament, you know what is its clinical relevance. I'll give you another very beautiful concept of the Berry's ligament. So when you look at the Berry's ligament, in general, when you're talking about the Berry's ligament has a very peculiar component. Now, what is that peculiar component is, imagine that this is the trachea that you're talking about. I'm taking an isolated trachea. These are the tracheal rings that we have. Then we say that there is a fascia that is attached here. This is your pretracheal fascia. Then I'm saying that you have this gland which is present here. This is going to be the thyroid gland. Now this thyroid gland is going to be covered by a fascia, and that fascia we are talking about is the investing layer of deep cervical fascia. Now imagine that this is the investing layer of deep cervical fascia, which is forming the pseudo capsule of the thyroid gland, and the posterior inferior condensation is resulting in Berry's ligament. Now you see that this investing layer deep cervical fascia, it is continuous with the occiput. It is continuous with the occiput. So what is happening is, it pulls the thyroid gland. Now you need to understand that this is attached in this way. Now easiest way to comprehend this information is, imagine that these two hands are your investing layer deep cervical fascia, which is attached to the thyroid gland. Now what happens is, this Berry's ligament, no, don't think the investing layer cervical fascia is coming from occiput to the thyroid gland. Imagine it is going from thyroid gland to the occiput. Put your thumb there and try to reach your occiput. Put your thumb right in the center where you have the thyroid gland and try to reach to the occiput. You will now feel the thyroid gland is pulled outwards and it is pulled backwards. It is pulled outwards, it is pulled outwards. It is pulled outwards, it is pulled backwards. So remember, the pull on the thyroid gland, the pull on the thyroid gland is going to be in two different directions. It is pulled out, this is going to be pulled out, and this is going to be pulled backwards, and this is the orientation of the investing layer deep cervical fascia. Can anybody tell me why this is important? है कोई बताएगा कि क्यों important है? Why did I tell you this in a very specific manner, that you need to know that the investing layer of the deep cervical fascia, or the Berry's ligament, which is attaching to the pretracheal fascia, actually pulls the thyroid gland is going to be outwards and backwards. Thyroid gland को वो बाहर और पीछे की तरफ खींच रहा है. It is pulling outwards and backwards. Is there a component or a reason that you know why it is happening? बताएगा कोई? Quick feedback. Let's see if you are able to tell. Why is this very important concept? बताओ यार, बताओ. Anybody? Okay, now you listen to the concept. You need to understand that when you talk about the trachea, it is made up of these cartilaginous rings which are quite strong. Now why I'm telling you they're quite strong is, during the inspiration, the air has to go in, right? Now when the air has to enter into the trachea, needless to tell you, the pressure inside the trachea has to be negative. So because of the negative pressure, the air is pulled into the trachea. But does the tracheal wall collapses? The answer is no. The tracheal wall does not collapse even though there's a negative pressure. Negative pressure is what? Negative pressure is basically a pulling pressure. Now imagine that I am the air and this room is the tracheal wall, and I am going to pull, because I'm a negative force, I'm going to pull the wall towards me. It's going to pull the wall towards you. So negative pressure is a pulling force. Now under that strong pulling force, you should notice the trachea should collapse. It does not collapse. Why? Because it says I'm strong enough. I am not going to budge to this negative pressure. So hence trachea remains patent even under negative pressure. Imagine if a trachea is going to become weaker. Now, for example, there's a tracheomalacia. Now, in a tracheomalacia, let's say, in a tracheomalacia, the wall of the trachea is getting weaker. It is becoming soggy, it is becoming floppy, it is becoming flappy. Usually seen in hypocalcemia. It can also be seen in long-standing goiters, which is exerting pressure on to the cartilaginous part, because they are, elastic in nature. Over a period of time, they become soggy, they become weak. Now the trachea is flappy or fobby. For example, we're talking about a condition like in tracheomalacia. Let's say I have a patient who is going to have a tracheomalacia. We have a patient who is going to have a tracheomalacia. Now in tracheomalacia, what is going to happen? During inspiration, again the patient is going to suck the air into the trachea. right? So the air is moving into the trachea under the influence of negative pressure. Now, because negative pressure is a pulling pressure and trachea is going to be soggy and weaker. Now, as the air goes, it pulls, because during negative pressure, the trachea has been pulled inwards. So you'll see the air is going to become a turbulent flow. Now, as the air goes as a turbulent flow, one, you will find this presence of stridor. So there will be presence of inspiratory there will be presence of an inspiratory stridor, because during inspiration the trachea is going to move even more closer, and as it moves, because of that floppiness of the trachea, the patient will develop stridor. Another very interesting thing is, even though there is a negative pressure, it is causing a pulling pressure, the trachea is soggy and weaker, the trachea still does not collapse completely. It is becoming soft, it is soggy. Under the negative pressure, the trachea should collapse, but trachea says, I will still not collapse. Who is preventing its collapse? Now the collapse is prevented by our good friend, which is here. You can see the thyroid gland, which is present in front here. This is the thyroid gland that you have, and we spoke that this is the investing layer of the deep cervical fascia. You see, this is the pretracheal fascia, which is also becoming soggy in this context, and you'll see that this is the Berry's ligament that is attached. Now we just learned the orientation of the Berry's ligament. It is going to pull the gland outwards as well as backwards, right? Now, as it pulls the gland outwards and backwards, and now because it is pulling the gland, it is also pulling the trachea. It says, no, I won't let you go. During the negative pressure, the trachea tries to collapse, and the Berry's ligament says, no, 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 I'm not going to let you happen. I'm going to pull the trachea. The air comes in the negative pressure, the trachea tries to move. The Berry's ligament says, no. So Berry's ligament is pulling the thyroid gland outwards and backwards. So even though there's a tracheomalacia, especially about a long-standing goiter, which is going to exert pressure on trachea, the trachea is going to become weak, soft, and soggy. But even if it becomes weak, soft, and soggy, it will not cause respiratory distress because the Berry's ligament is preventing it. Now the question is, why it is important for me as a surgeon? Now, if I don't know this, I do not understand the presence of inspiratory stridor in a big gland indicates tracheomalacia, and I become a hero. I go into the surgery, I take this Berry's ligament out, I take the gland out, and post-operatively what is going to happen? There is nobody who's pulling the trachea outwards and backwards. So what is going to happen? During inspiration, the trachea collapses. Post-operatively, patient goes into severe respiratory distress. Do you want that to happen to your patient? Do you want this to happen to your patient? Quick feedback, guys. Would you want this to happen to your patient? Do you want your patient to suffer because you didn't understand this concept? Do you want to do that? The answer is no. I would not let this happen to my patient. So I would understand this concept. So any patient who has a tracheomalacia pre-operatively should be managed for tracheomalacia. Make sure the trachea regains its integrity and then operate to prevent post-operative tracheal collapse or respiratory distress. I hope everybody understands this concept, no? Right? So this is, see, there's beautiful things around it, right? Understanding anatomy, just as anatomy, is no fun. Look at the anatomy from a surgeon's perspective. I'm telling you, there is symphony. You know, there's an art that is there in the body. Every single structure that is, put, the muscle, it's just not randomly put. The fibers are going here in this way, they're going here in this way, they cross at some point. Every single structure is designed with a purpose. And that is how we should be in our life. Every single thing that you do in your life should have a purpose. I am telling you again, as you travel, I know the goal is important, the destination is important, but trust me, the journey is equally important. देखो याद सिर्फ जर्नी रहती है, डेस्टिनेशन नहीं. डेस्टिनेशन आने के बाद सुकून मिल जाता है, लेकिन जब आप उस सुकून वाली जगह पे रहते हो तो याद हमेशा आपको अपनी जर्नी आती है. तो जर्नी इतनी ब्यूटीफुल बनाओ कि जब डेस्टिनेशन में पहुंच जाओ ना, तो जर्नी का रिग्रेट ना हो. ठीक है? विद दैट, a very important concept or the component that you need to understand with respect to our Berry's ligament है बहुत छोटा सा, इतना सही है. ठीक है, जो छोटा सा अटैचमेंट लेके बैठा है, लेकिन इतना दम है ना कि बेटा ट्रेकिया बचा रहा है वो. ठीक है, इट इज मेकिंग श्योर कि ग्लैंड ने अगर ट्रेकिया को दबा के भी रखा है ना, इसने ठान ली है कि मैंने नहीं उसको कोलैप्स होने देना. तो द साइज does not matter, right? You need to understand it is the strength that you brings in from your determination, and I want you to be in that context as well. Yeah, usually it is an inspiratory strider because negative pressure pulls, no. Expiratory strider is just exhaling out. ठीक है? Clear? So deformity of the trachea occurs during inspiration. Great. So what are the other berries that we know? बहुत berry सुना होगा. तो क्या है? What are the other berries that you can talk about? One, we already spoke about the berries ligament. The other berries that I can talk about is berry sign. Now, what is this berry sign? Berry sign is described as an impalpable carotid pulse. This is defined as an impalpable carotid pulse at its normal location. It is an impalpable carotid pulse at its normal location. Do not say absent carotid. Beta asgar wahi to galti hai. Absent carotid is incompatible with life. आप ऐसा बोल ही नहीं सकते कि भैया कैरोटिड एब्सेंट है तो मर जाएगा पेशेंट. आप बोलोगे द कैरोटिड पल्स इज इम्पैल्पेबल एट इट्स नॉर्मल लोकेशन. So what is the normal location? If I ask you to palpate the carotid pulse, which carotid pulse would you like to palpate? Is it the common carotid, the internal carotid, or the external carotid? Remember, you will palpate the common carotid. Every arterial pulse is palpated against the bony landmark. So when I say common carotid, it is palpated against the spinous process C6 vertebra. But unfortunately, I cannot locate it by palpating it. So what is the surface landmark? The surface landmark is draw a line that passes through the anterior border of your sternocleidomastoid muscle. Draw another line that passes through the superior border of your thyroid cartilage. The point where your anterior line, the line which is passing through the anterior border of sternocleidomastoid muscle, and the line that goes from the superior border of the thyroid cartilage, when these two lines intersect, this is the point where you feel your common carotid. So I am saying you that there is impalpable carotid pulse at its normal location. So why is it happening? It usually happens when the gland becomes large enough. When a big gland occupies the entire neck, pushes the common carotid behind the sternocleidomastoid muscle, and you are trying to palpate in front. Are milani, kaise milega? You know, the carotid is pushed behind. A large gland pushes behind the carotid vessel, behind the sternocleidomastoid muscle. You will not be able to palpate at normal location. Another one, if there is a malignant infiltration of the carotid sheath, which is comprised of common carotid internal jugular as well as your vagus nerve with lymphatic channels, so that carotid sheath, when it gets infiltrated again, you will not be able to palpate your carotid pulsation. So when I say berry sign positive, it is impalpable carotid pulse at its normal location. कभी नहीं बोलना कि absent carotid pulse है, वरना आप absent हो जाओगे. Is that clear? चलो. So we have the Berry's ligament that we spoke. Then we have the Berry's sign that you spoke. Then you have the Berry's aneurysm. So when I say Berry's aneurysm is the aneurysm of the circle of Willis. It is the aneurysm of circle of Willis. Right? Now remember, it is the overall most common site for aneurysm in the body. This happens to be the overall. This is the overall most common site for aneurysm in body. It is the overall. This is the overall most common site of aneurysm in the body. That is your Berry's aneurysm. So we spoke about the Berry's ligament, we spoke about the Berry sign, we spoke about the Berry's aneurysm. Another Berry that you need to remember is what we call it as the berry picking. Now we don't do it any longer. It has now become an obsolete process. But from the standpoint of exam, we'd like to discuss it. What is berries picking is? It is to hand pick. It is to hand pick and remove enlarged cervical lymph nodes enlarged cervical lymph nodes during surgery in papillary cancer thyroid. So any patient with a papillary cancer thyroid, earlier, the surgeon used to palpate the neck, and if he's able to feel those lymph nodes which felt enlarged, hand pick and remove it. It is called as Berry's ligament, or sorry, Berry's picking. As of now, Berry's picking is contraindicated if there is a palpable lymph node. The current guideline says go ahead and do a central neck dissection. Go ahead and do a central neck dissection. So this is all that you should know with respect to Berry's. So small concept of Berry's ligament has unfolded into these beautiful subsets, which now makes us understand the thyroid swelling even better. Okay. Now, coming back to our original discussion. So I said we have a patient who is going to present to you with a midline neck swelling, which is painless, gradually increases in size. It is a non-tender swelling. It is uniform and smooth surfaced. When you palpate it, moves out the degglutination. Another point that I can add here, it is not only smooth, it is also going to be soft in consistency because it's a cystic swelling. Because it is a cystic swelling, right? So what can you do? What you can do is you can do another clinical test. Now on this, you will see that thyroglossal duct cyst, every other swelling that we spoke about, that your thyroid swellings, your thyroglossal duct cyst, your subthyroid side is your enlarged pretracheal lymph nodes, everything moves upward degglutination. The only swelling that moves upwards with protrusion of the tongue. See, I've told you every other swelling that is going to move upwards with degglutination. Thyroglossal duct cyst is the only swelling that is going to move upwards with the tongue protrusion. It is going to move upwards with the tongue protrusion, right? So when we say it is going to move upwards with the tongue protrusion, as we say it is going to move upwards with the tongue protrusion. Why it is going to move upwards with tongue protrusion? If you are my student, you wouldn't ask that question. Kyun chalega? Kyun chalega? Kyunki this band is still attached. So every time the patient sticks the tongue out, the tongue pulls out, the duct is going to pull this gland up. So the swelling is also going to move upwards. Every time the patient tongues move out. So it's like tongue sticking out. So this is the duct that is present. The tongue is sticking out, right? The tongue is sticking out. As the tongue sticks out, you see this is the swelling. Tongue sticks out, swelling moves. Tongue sticks out, swelling moves. So the movement of the swelling every time the tongue sticks out is because of this attachment. And this attachment is your thyroglossal duct cyst or the thyroglossal duct's remnant. So it not only moves upwards with degglutination, it also moves with the tongue protrusion as well. Is that clear? Right? Now, we have our own patient. I would like to introduce you to her. She is our Aji. So we'll try to show you that what we have for her. I'm just going to put that video. So we have one of this patient who was presented to us. I'll just give you a background story and a history as well. Right? So when you talk about this Aji that we have, okay, time to mark. Okay. Now, before we move down, I'll give you a small basic background about this female that we saw, right? She's a 48-year-old female, coolie by occupation. Her basic job was a street vendor and a hawker. She used to go door to door, sell pickles and make her livelihood. That's her basic thing. Now, why did she come down to us? She came down to us with a complaint of the swelling in the midline of the neck. I would like you to appreciate that swelling. Now, this is the midline of the neck we're talking about, and this is where the swelling is present. Okay? So she came to us with this particular swelling, right? So we said there is this swelling in the midline of the neck. I hope if I clean it up, you will be able to see it again. So this is the swelling. So this is the swelling I'm talking about. Okay? So this is the swelling in the midline of the neck. I want you to focus across here. I asked her, when did you first notice? She says, when I was, early 20s, or I say around 17, 18 years is the first time when she noticed the swelling. And I said, then what took you so long to come? She's like, in all these 30 odd years, it never bothered me, right? It was there, I was there, so we were both chilling together. We really didn't have a problem. I said, okay, great. So what brings you now today? She says, my neighbor recently developed a similar swelling in the neck. We don't know what happened, but she died because of that. I said, how did she die? She says, she went to the hospital. They diagnosed it as cancer and then she died. I am now worried that I might have cancer. I'm like, okay, great. Now she has come to us with fear, so we are going to address it, right? So you need to understand that she is a female, a 47-year-old with the complaints of the swelling in the midline of the neck. This swelling has been there for last 30 years. It has not progressed in size. It is painless. And now on a clinical examination, this is what you're going to see. Now what is going to happen? See across here, I'm asking her to swallow. Every time she swallows, look at my finger. It is going to move upwards, right? As she swallows, it is going to move upwards with degglutination. And now I want her to stick her tongue out. Every time she look at it, out, yep, goes down, up, goes down, goes up, up. So every time she swallows, it moves upwards with degglutination. Originally, I wanted her to do like this, rapidly move her tongue in, out, in, out. So I wanted her to do like this, rapid movement of her tongue in, out, 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 so that the swelling moves upward with the protrusion of the tongue. I asked her to do that. No, she said, get lost. I can't do that much fast, right? But originally, to appreciate this movement, you have to ask her to put her sting out and in, and that too on a rapid basis. So now I have a patient with a midline swelling in the neck from last 30 years. It remains painless. It has not progressed even a bit. And now on protrusion, on swallowing, it is going to move upwards. If you have appreciated, you would have noticed that this swelling is going to move upwards with swallowing as well. I ask her to swallow. Yeah, you see that most classical movement with the swallowing, right? So swelling moves upwards with degglutination as well, but at the same time it also moves upwards with the protrusion of tongue. Here you can see it is going to move upwards with protrusion of the tongue. Every time she sticks her tongue out, it protrudes out, right? That movement is going to be quite important. Did you all appreciate that? Quick feedback. Did you all appreciate that? क्लियर है? Guys, I want feedback. नहीं बताओगे तो पता कैसे चलेगा कि आई बात समझ में कि नहीं आई? हाय उसामा, गुड इवनिंग. ठीक है, सॉर्टेड. चलो, लेट्स गो बैक to our lecture. So now you have a patient who has presented to us, right? So you have a patient who has presented to us with all these features that are present, right? I would like to investigate, right? Now, in terms of investigation, that you want to know what exactly it is. Now, for all thyroid associated swellings, what are the investigations that you'll do? You'll do an ultrasound of the neck to identify the source of the swelling, size of the swelling, the consistency of the swelling, the vascularity of the swelling. Now, once you've done the ultrasound of the neck, I would also like to do a thyroid function test. Any thyroid or midline neck swellings, no, you should always consider that they're probably a thyroid swelling, so always do a thyroid function test before moving forward. And once you've concluded, you should also perform FNSE of the swelling, that is a fine needle aspiration cytology. Now, the reason why I would recommend an FNSE is the Thyroglossal Duct Cyst increases the risk for papillary cancer thyroid. It increases the risk for papillary cancer thyroid. It increases the risk for papillary cancer thyroid. So in order to make sure that the patient does not have such, always do an FNSE as well. But before doing FNSE, always do a TFT to confirm whether it's a U or a hypothyroid status, right? Now, once you've decided, I would like to operate. The management for this condition is going to be surgery, and the surgery of choice is going to be cyst trunks operation. It is a cyst trunks operation. So what do you do in a cyst trunks operation? We are going to remove a part of the hyoid bone. So we're going to remove the part of the hyoid bone. We're going to remove the part of the hyoid bone adherent to thyroglossal duct cyst along with the cyst. We're going to remove the part of the hyoid bone. We're going to remove the part of the hyoid bone adherent to the thyroglossal disc along with the cyst as well. Safia, welcome. Sir, first year here. I'm feeling nostalgic studying surgery. You're already feeling nostalgic studying surgery, yeah? Okay. So let's see what is the cyst trunks operation is all about. So let's say this is the hyoid bone that you have. And this is the thyroglossal duct cyst that we have. So let's say this is where the cyst is going to arise, and this is the thyroglossal duct cyst that is going to be present here. So this is the collection that we have across here, right? Now in a cyst trunks operation, what are we going to do? We are going to excise the part of the hyoid bone. So I'm going to excise the part of the hyoid bone that is adherent to the cyst along with the cyst wall. So this line demarcates that we are going to remove the hyoid bone that is adherent with this, right? So once you remove this part, right, what are you left out with? Once you remove this, so whatever I'm removing, I'm going to shade. I'm going to remove the entire cyst wall. I have to remove it en masse without causing any puncture or any damage and avoid the spillage, because a clean extraction is always better. So whatever I've shaded, no, that part we are going to remove. So once you remove it, what is the end result that you have? The end result that you're going to have is going to be this. So you see, this is the hyoid bone. So this is the hyoid bone that is left behind, and this is the part of the hyoid bone that is being excised, right? This is the part of the hyoid bone that is excised. So along with the entire component, so what you have removed out of here, so what you have extracted from here is the part of the hyoid bone. So this is that part of the hyoid bone that we have excised. Along with this part of the hyoid bone, I have taken out the entire cyst wall, right? So I have removed the entire cyst. So this is the cyst that was present. So the entire cyst, which is adherent to that of the hyoid bone, along with the fragment of the hyoid bone, is also removed, right? So this is what we call it as the cyst trunks operation. So in a cyst trunks operation, not only we remove the entire cyst en masse, that means without causing any damage, we also remove the part of the hyoid bone. We also remove the part of the hyoid bone that is adherent to that of the cyst. So when you look at the specimen, you will see this is the part of the hyoid bone. This is the part of the hyoid bone, and this happens to be the thyroglossal duct cyst. This happens to be the thyroglossal duct cyst. Okay? So this is what we call it as the cyst trunks operation. This is what we call it as the cyst trunks operation. Clear? So this is all that you should know in the context of thyroglossal duct cyst. सर थायरोग्लोसल सिस्ट फ्लूइड फिल्ड होती है या सॉलिड होती है? बेटा सिस्ट नाम खुद बता रहा है ना, इट इज फ्लूइड फिल्ड. ठीक है, इट इज गोइंग टू बी फ्लूइड फिल्ड कंपोनेंट. सो आई होप यू एंजॉयड द टॉपिक फॉर टुडे. एनी क्वेश्चंस, एनीथिंग दैट यू वुड लाइक टू आस्क, एनी फीडबैक दैट यू वांट टू गिव? कुछ बोलना है, कुछ बताना है, कुछ इजहार करना है, कुछ भी, क्या करेंगे? Do you want me to continue with another topic? है एनर्जी या फिर रिजर्व करें अगले सेशन के लिए? क्या बोलते हो? Shall we continue? Shall we reserve it. But it's not, see, trans-elimination positive ke liye, you need to have a clear fluid. Here, you would have a slightly turbid fluid. You will not get a positive trans-elimination. In the neck, you will get in cystic hygroma. A positive trans-elimination is seen in cystic hygroma. Clear? Hi, Mission Smile. बेटा आपका नाम Mission Smile है तो पता नहीं क्या मिशन पे निकलो. Rahul, why is Harrison stopped? It is not stopped. Santosh is taking a small break, and we all love Santosh sir for Harrison series. He will continue. If he is not continuing, we are going to push him to continue. Okay? Okay, so what we'll do is, yeah, we'll keep the series to the same time frame so that it does not get an overcook also. So we're going to stop the session for today here. Again, very interesting session from my end. I would love all you guys to have more interaction. I would like you to give me more and more component. Sir, continue. Beta, continue. It's a 3 days a week. And I've given you the 4 days of mega day per day. That is, see, every week where I feel, no, where I want to do a little bit more and I see you guys being more enthusiastic, I will add. आप पूछोगे तो मैं करूंगा. ठीक है, ये म्यूचुअल है. देखो यहाँ मैं अकेला खड़ा हूं इन अ स्टूडियो, कोई भी नहीं है. अपने it feels almost कि मैं अपने आप से बात कर रहा हूं. Only when you guys give me that feedback on that chat box, no, that is the driving force. You guys have to tell me कि सर करो और करो, इसको और बेहतर करो, and that is where we both will benefit. I would like to impart and share all the knowledge, and I would want you guys to benefit from it. At the same time, यार हो तो ह्यूमन बीइंग ना, थोड़ा मोटिवेशन मुझे भी लगता है. ठीक है. The most common nerve injury in a thyroid surgery is the external branch of the superior laryngeal nerve. ठीक है. So superior laryngeal nerve injuries are more common. अगर आप पूछ रहे हो in terms of the incidence, और यही आपका नीट पीजी में भी सवाल आता है. ठीक है. With that, signing off for today. Thank you so much. Again, I'll be posting the notes in our Telegram group as well as the Instagram group. Please do follow me on the Insta. That is the surgery guy. Again, it is by me, that is Dr. Sandeep Seeram Reddy. The same thing, you can find it on the Telegram group also, that is by the name of the surgery guy. Okay? So any questions, any queries, anything that you want to feedback, again, you can reach out to me on the Instagram as well as on the Telegram group. BLS series will run every week, Monday, Tuesday, Wednesday, evening 9 to 10 o'clock. That is when you have your dinner time. All that you have to do is to eat and watch BLS. Aram se khao, aram se dekho. You will feel. I'll make sure the whole session remains interesting. We'll incorporate diagrams. We'll incorporate drawings. We'll put a lot of clinical videos. When the surgical video starts popping in, I will make sure the surgeon inside you has to be awakened. Okay? Asghar, I would love to do the entire session in Hindi बेटा, लेकिन मेरे पास पूरे इंडिया से ऑडियंस है तो हर किसी को हिंदी नहीं आती है. मैं ट्राई करूंगा कि जब भी कोई टॉपिक ले रहा हूं उसको मैं क्विकली हिंदी में भी समझा दूं, बट मेक श्योर कि हमारा सेशन बैलेंस रहेगा. आई विल रियली कंसिडर कि हाँ, हम हिंदी में भी लेंगे ताकि every audience or every subset of audience who is listening should get benefited. तो every single lecture जो हम इंग्लिश में पढ़ाएंगे वही हम हिंदी में पढ़ाएंगे. ठीक है. With that, thank you so much. Keep watching, keep your. So if any, ये जो हफ्ता अभी निकलेगा ना, फ्राइडे सैटरडे संडे 3 दिन जो बचे हुए हैं, उसमें ना थोड़ा ब्रश अप कर लेना ये सारा जो भी पढ़ा हुआ है, भूलना नहीं है, क्योंकि फिर मंडे ट्यूसडे वेडनेसडे वापस मिलेंगे और तब बात करेंगे मेजर टॉपिक्स की. थायराइड में गॉइटर, टॉक्सिक स्वेलिंग्स, इन्फ्लेमेटरी थायराइड स्वेलिंग्स, फिर मैलिग्नेंसी. अरे मजा आ जाएगा. ठीक है. विद दैट, thank you so much. Right. With that, signing off. Have a good time. Have a great time. And as fellow doctors, watch out for each other. Be safe when you're working. Be safe in your own environment. Let's not indulge into any unwanted thing. Our life is much more precious, and you guys have a huge future and a bright future altogether. So happy Children's Day. Thank you. Signing off.